You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
You're listening to the NASP Specialty Pharmacy Podcast, a collaboration between the National Association of Specialty Pharmacy and the Pharmacy Podcast Network. Each episode dives deep into trends, challenges, innovations, and patient-centric practices shaping the future of this dynamic and rapidly evolving industry. Whether you're a pharmacist or healthcare provider, patient advocate, or industry leader, you'll hear expert insights, real-world evidence, and thought-provoking discussion that highlights all that makes specialty pharmacy special.
In support of NASP's mission to empower specialty pharmacy stakeholders to advance the standard of patient care, NASP supports a free market healthcare system in which all specialty pharmacies compete on the same fair and level playing field, because that is in the best interest of the patients we collectively serve. NASP is committed to working with all stakeholders and policymakers to ensure that all patients have access to the life-saving medications they need and the high-touch patient care and support services they deserve from the pharmacy of their choosing.
Hello, my name is Sheila Arquette, and I'm the President and CEO of the National Association of Specialty Pharmacy. I'm delighted to welcome my special guests, Diane Omdahl and Sheri Wallace, to this episode of the NASP Podcast. For more than 40 years, Diane Omdahl, RNMS, has kept her finger on the pulse of ever-changing Medicare regulations. She's a registered nurse who launched her first company in the basement of her home and grew it into a multi-million-dollar business, providing Medicare-related training for long-term care businesses. Over the years, Diane has delivered more than 500 Medicare-related presentations and webinars to consumers, professional organizations, and companies, including Edward Jones, Allstate, FPA, and more, making her a very experienced and highly rated speaker. Today, through her company, 65 Incorporated, Diane uses her extensive experience to provide seniors, their families, and the professionals that serve them with unbiased, individualized Medicare enrollment guidance through fee-for-service consultations and the I-65 Medicare guidance software. Diane also works with the nation's foremost corporations like PBS and Macmillan Publishing, providing their human resources staff, employees, and retirees with expert, unbiased Medicare consultation and speaking services. Diane has been featured in publications such as USA Today, The Washington Post, The Wall Street Journal, CBS Money Watch, Kiplinger, and many more. She is also a technical expert for the Centers for Medicare and Medicaid Services, the organization that runs the Medicare program. Additionally, Diane's book, Medicare and You, is available at Humanix Books. Sheri Wallace is a dedicated sales executive with over 20 years of experience in patient access and healthcare solutions. Currently an account representative at AcariaHealth Specialty Pharmacy, she has spent the past 2.5 years delivering results that directly enhance the patient experience. Sheri's passion lies in advancing sustainable, best-in-class patient care, ensuring that every initiative she leads empowers, educates, and supports all stakeholders in the healthcare journey. Her consistent top-tier performance is driven by a deep-rooted belief that every success must ultimately benefit the patient. Sheri is a true advocate committed to making healthcare more accessible, compassionate, and effective for those who need it most. Diane and Sheri, thanks so much for joining me today.
Thanks for having me.
Yes, thank you too.
So Diane, for those unfamiliar, what exactly is the Medicare Prescription Payment Plan, or M3P, and why is it often referred to as smoothing?
The Medicare Prescription Payment Plan is a new program that started January 1st of this year. The introduction coincided with the $2,000 cap on Part D drug costs. That $2,000 cap is the most anybody would pay for medications out of pocket that are covered, meaning listed in a plan's formulary, and obtained from an in-network pharmacy. If a person is going to hit that $2,000 cap in January, that can be a real big hit in their budget. So the Centers for Medicare and Medicaid Services came up with this MPPP or M3P. It is like the old department store installment payment plans. You have a $2,000 bill, and they split the payment into equal amounts that will carry from January through December. And so therefore the smoothing comes into play, which means instead of a big hit of $2,000, you have a nice smooth ride. The ride isn't always that smooth, as you will hear, and there can be hiccups. And I guess that's why we are here today talking about the program.
Sheri, any insights?
It can be really helpful for patients who don't have on a fixed income the amount of money necessary to pay for like their biologic or some sort of the high cost drugs. So it can be really helpful to them, but I think there are pitfalls which we can discuss as to just making sure that they understand how that's going to be billed to them and what that impact is to their coverage overall.
So Diane, can you tell us what inspired you to focus on M3P for this podcast?
I think what inspired me to focus on it is because it is confusing. It is not a program that has the kind of numbers that the government would think that it would have for the number of people with high drug costs. And I think part of that comes into the reason being they don't understand the program. Some of the things about the program I think we should lay out is that participation is entirely voluntary. Well, that is until next year, and that will come. But anyway, it is up to you to decide whether you should enroll. If you have the high drug costs at the beginning of the year, you'll get notified by your plan. Now, let's say you don't have high drug costs in January, and you go to the pharmacy in May, and suddenly you have one of these high-cost drugs that's going to be $2,000. The pharmacy will give you a notice called the likely to benefit that explains what the program is, and then you can decide if you want to enroll, and then your costs will be smoothed. I already mentioned it's only for covered medications. Once you're in the program, there is no co-payment or cost sharing that you will pay the pharmacy, and I think that might be one of the reasons people are reluctant. They are going to get bills from their drug plan. Now, the bills are not the amount that they would think sometimes. You take an amount, divide by 12, but there are involved calculations that drug plans use, and they will send you the bill. Then you have to arrange to pay it to them, not to the pharmacy. Then you pay these bills on a monthly basis, and the amount of the bill can change. Why it is not more, why there are not more people involved, I really have no answer, except CMS has not done much to promote it. We have done some education here, but many of our clients decide, I don't want to change the way that I pay for the medications. I want to know what I'm paying now. I don't want to deal with monthly bills from my drug plan because if I try to call them, I run into problems. So there's many of those reasons. And we decided we're going to focus on it to kind of let the pharmacists know that it's out there because they play an important role in notifying people. And Sheri can speak more to that.
Right. So as you were talking, it just got me thinking, Sheri, who pays the pharmacy? How do they get paid?
CMS pays the pharmacy. So the patient really is in a different position because they can walk out of the pharmacy and not pay anything, but then they are going to get a bill from their plan. As to why people are not enrolling, and the last numbers I had showed it was less than 200,000 people that had enrolled so far this year. Those are a couple of months old, but I don't think they've significantly jumped by any large amount. We at the pharmacy, when we talk to patients on the phone about their coverage, we'll say to them, your doctor prescribed this medication to you, and this is what the out-of-pocket cost is for you at this time. And then we have this option for you to talk about, the M3P plan. Patients hear that big number with $1,000+ after it, and they don't understand about paying for, they don't have the money to pay for that. They're also, remember that people are getting a lot of medications at the pharmacy that aren't triggering the knowledge of this plan. So say they get Eliquis, which is I think the most commonly covered, high cost sort of regular prescription drug for CMS. So if they're picking up their Eliquis prescription, they can be spending $150 to $300 a month commonly. So they are already facing that monthly cost, and they don't understand how that would integrate into the M3P out of pocket. So unless we get patients started right away at the beginning of January, if they've already paid for Eliquis, they may not have the money for that next bill to be coming. Remember, these are all people on a pretty solidly fixed income monthly. And so I think where we see people drop off largely is right in the very beginning, where they hear that what they consider the copay, but what's the out-of-pocket cost for them on their plan for this medication. And it just seems insurmountable. And so when someone's trying to explain to them what this is, they're not they don't even stay on the phone. If you listen to them or read the notes, a lot of patients aren't even staying on the phone to hear about the options for paying it. They're just like, I can't afford this. I'm going to go talk to my doctor. And whether they even show up and talk to their doctor after that, it varies. Like, we start to just see people drop off there rapidly to the point of, very few people actually getting that medication, which already is a problem with some of these high-cost drugs. The number of prescriptions written compared to the patients who actually can receive them is quite different.
Is there a requirement for the pharmacist to describe or explain this program to the beneficiaries?
Unfortunately, there is no educational requirement to my knowledge. Pharmacies do not have to provide education to the patient about this. We do at AcariaHealth. We provide that as part of educating the patient, and we'll answer questions, refer them to their plan. We can even be on the phone with them while they talk to their plan. We can talk to the doctor, who can talk to the patient and have the patient come in. And often the doctor is a more trusted source, because remember, we're on the phone at the pharmacy level with them. But they, a lot of times if they're at their retail pharmacy, the person there isn't educated to help them, even if they wanted to. And because there's no requirement, they just aren't getting, counter education at their typical point of getting one of these medications. And if it's your first time getting a specialty drug, remember that this is a big educational jump for patients anyway, because there's a lot that comes with these medications. There's a lot of training for the medication. There's a lot of details. There's a lot of things that patients are already worried about because of why they're getting the medication, what may be going along with that. There's a lot to take in. And so I think that we're just not, overall, we're failing, all of us in the community in the village, of getting people their medication. We're all failing at getting all the information to the patients as best we can. And there's just loopholes everywhere.
CMS does not require the pharmacy to provide education. So Sheri was correct. It is up to the plan to do that. And anybody who has ever tried to contact a representative from their Part D plan knows the problems that are involved. Now, 2026, one of the regulations that was finalized has to do with informing the drug plan members about the cost of a drug. CMS had put forth that at the time a prescription is delivered, the pharmacy is supposed to give the price, the out-of-pocket cost to the patient. But what ended up being finalized was that they do not have to inform them of the actual cost of the drug at the point of sale, but CMS encourages them to leverage standard industry data to provide costs verbally upon request. So if the patient requests an idea of the cost, they will get kind of a ballpark number. And as Sheri and I were discussing, if I don't exactly know how much I'm going to pay for this drug, I'm just going to leave it sit there with the pharmacist. And then we could figure this out later. And then as a result, we do not get the medications that we need.
So this is a lot of change for these beneficiaries. How do you see this impacting patients directly, especially those who are already struggling with access or affordability, Diane?
Oh, definitely the confusion. And I would just, if I was in that situation and on a fixed income, I would definitely decide to run away and go to talk to my doctor, as Sheri has said so many do. We deal with so many people, and these people, many of our clients are not on fixed incomes, and even they have opted not to, because I think they do not trust the drug plans to have the bills be correct. They know that if there's a question about the bill, they're going to have trouble getting it clarified. So they just would rather continue to pay the way that they pay. And as I said, some of them, good chunk of them, can afford the cost. But people who are on mail order, they pay once every 3 months. You go into the plan, you're paying monthly. And is it any wonder, trying to figure out the numbers, exactly how much I pay a month, does that match what I'm supposed to pay? That's where the confusion comes in. And I agree with the numbers that Sheri had put forth, because people aren't signing up. And I don't know if it's going to become much better with some of the changes that they put forth. Sheri mentioned there's no requirement for them to enroll, but those people in the plan, as we talk right now, if they're in the MPPP and they continue with the same plan, which not a real good chance of that, but if they continue with the same plan they're in, they will be automatically enrolled in the program unless they opt out. And we know people rarely opt out when given the opportunity to, because they may not be paying attention or whatever. So they would program next year again. And as I said to Sheri, and neither of us know, what if the expensive drug that I took at the start of the year that put me in the program has been discontinued and I no longer would have those costs? Will I get automatically enrolled in a program where the costs are going to be crazy? Just so much unknown. And I often say, I think the people at CMS who developed these programs have not been down here where Sheri and I live to see how the rubber meets the road. And you can't get there from here sometimes, is always been my approach with Medicare and some of the rules.
Right. I guess it probably makes sense from the perspective of, oh, geez, we don't think a lot of people know about this. So it looks like these people would have benefited from it and we're going to auto enroll them. But to your point, not thinking, oh, something may have changed. Right. And maybe they no longer need this. Maybe they're on something else. Maybe. Right. So then how do you capture that? So I think sometimes they have the best intentions. It's just not fully vetted.
Correct.
Yeah.
What we see on the specialty pharmacy side is that, like most things with high cost drugs, it falls on the prescriber's office to do the bulk of the education here if patients are to receive those meds. They're coming in because there's a follow-up criteria determined. The provider, if they're prescribing a drug like this, has requirements to see the patient every so often, determine efficacy, et cetera. So the patient is going into a trusted source and a safe space where they're already comfortable discussing things. And so the patients really depend on their providers to be able to explain how this program works and also explain to them and remind them. I mean, I forget things all the time, and I don't have to worry about this medication thing being one of them. But if you start on a medication and then you want to change or opt out of the M3P as it goes, into next year, the prescriber's offices are the wonderful source that patients do have. But access to their office, that's also, there's a hurdle there, that many hurdles. But when you do have a prescriber office, they're really the central clearinghouse functionally that works to get patients the info. Like, we'll call them and say, hey, your doctor prescribed this for you and here's the pathway. But often the patients depend on the doctor's office or the prescriber's office to really help them through all the steps and help them, unenroll at the end of the year or explain what their notices mean. So as part of educating the offices, it's like full speed ahead this time of year anyway. The medication coordinators call it blizzard season, and that's when everybody's plans are changing and things are changing, formularies are changing, everything. And so I'm educating the offices so that they can better help the patients navigate all these little intricacies to say, hey, if you don't want to sign up for next year, or if your Medicare plan is not being offered next year, which many of them aren't, you're going to have to sign up again for this. And so the prescriber's office is going to also be able to help the patients if they're educated and willing, which in my experience, they really are, but they can stage the medication prescriptions. They can sample a little bit at the end of the year. They can really work with the patients to get them started on the right schedule that meets their needs. So the bills will come, when they need the bills to come. The prescriber's office really has just gotten this basket dropped in their lap. And so on top of the other costs and efforts it takes to get access to these medications, this is really falling on the prescriber's offices, which is why they're leaning on specialty pharmacy for help with this.
And I think I need to add another change for 2026. Let's say that the prescriber's office does convince the patient that this program would be beneficial. In 2026, these patients cannot sign up at the pharmacy counter. They would have to enroll through their plan. So we circle back to all of the problems that people have trying to figure out, how do I enroll through my plan? I actually spent an hour trying with the different drug plans, trying to see where I would enroll on the website. Nothing is consistent. Nothing is standardized. And in one plan, I couldn't find a place where I can sign up for this program. So taking away signing up at the pharmacy counter, I think, is only going to add more hurdles to getting the necessary medications.
It's a lot to put on any one stakeholder, right? Like we're talking about, putting it on a provider, and Medicare's not the only payer that they deal with, right? So patients are expecting them to be experts on all of these plans, right?
Correct.
Not just for beneficiaries, but then for the commercial market and the exchange and, self-funded, and it's a lot.
It's a lot. And the medication coordinators in these offices, I can't say enough as to what they do to provide this key access point for patients, because they know so many things about so many plans. They know the intricacies of what's on the formulary and which stage. And remember, drugs come out all the time. Mm-hmm. So I'm speaking like from a specialty perspective, but I was just in office yesterday and saw that I saw that it had cleared the FDA a couple of weeks ago, and now it's being sampled and it's available in the office. So we were discussing, does this fall before or after in these formularies for access? So would you have to prescribe this before this drug, or would you be able to prescribe this drug first? So they not only have to get the patient that's in front of them, like we're just talking one discrete example of working with this particular Medicare patient for this, but they have to have, by the time the patient's gotten here, that coordination has already gotten the prescriber the information that says, okay, this is where we're headed, but this is the steps that the patients are going to have to go through. This is what's on formulary with their plan. This is what's excluded. They're going to really be understanding and helping the prescriber in all steps of this, which is why I think we see so many challenges at the provider office level currently, as they're struggling to fund all of this manpower in their office, in addition to being healthcare providers.
Yeah.
Mm-hmm. And I think, the pharma companies are also really struggling to be helpful and help this, but they only have their piece of the puzzle. Like, so many people enter this system siloed that it's very difficult to get all pieces of the puzzle to make the puzzle. It'd be like trying to put 1,000-piece jigsaw puzzle together and you're missing like 250 pieces or many more pieces, depending on which silo you're coming from, trying to get somebody, through their chutes and ladders game.
And I've always said, you don't have a picture on the box to help you.
No. Mm-mm.
I wonder, Diane, how long it'll be before Medicare Part D, stipulates where it has to be on the website, right, to standardize that? Because I think they do a pretty good job of trying to make sure that, the benefit is applied consistently, right, to all beneficiaries. So I wonder if that's coming.
Right now, I think CMS has their hands full with trying to standardize the websites for the Medicare Advantage plans, the network directories, and the supplemental benefits, which is another entire can of worms.
Another important piece of information for providers' offices and patients alike is that since this program came into play this year, which will be last year, next year, in 2025, we have seen one pharmaceutical manufacturer require enrollment, a proof of active enrollment in the M3P program prior to them offering PAP or patient assistance to patients for medication cost assistance. And so that is only one manufacturer that does it for all of their lines or all of their products. But I believe we'll see this more and more in 2026. And our pharma partners have confirmed this when we've been talking, kind of just informally. Currently, we have quite a few of the manufacturers asking patients to certify that they have signed up for the M3P, but it's just an assertion that they can fill out, send in, and then the PAP applications are processed after that. Some are requiring them to to do some sort of proof, like a piece of paper showing that they've signed up for the M3P. And I think that's going to be the standard that we're going to get to by the end of 2026, because the pharma companies are, in the office when you're really, really busy as a provider, it's tempting to be like, okay, the patient can't afford, they're out of pocket. It's troublesome to get the PAs. It's, and so the offices and the patients alike, everyone's really leaned on the pharma partners to come up and provide this no-cost medication through their PAP programs. But pharma can't be expected to do that, especially with everything else that's going on. And when we think about how these, especially in the Medicare with M3P, this is really limiting the amount of money that's being paid to the plans for these drugs. Something's got to be able to give here. And so I think that we're just going to see these patients having to actively enroll and show proof of it. So the knowledge of how to get this done in the office, where to go for each plan, what the link is for each plan, the education on how to do it. And then for the patient who says, okay, I'm going to actively enroll, but then and I'm going to do that. But then there's a time limit there where you actively enroll, medication is dispensed, you get a bill. When does PAP come in? How is that being handshaked between everyone involved? Because there's several partners there, and maybe a couple different types of pharmacies. If the pharma partner is, self-dispensing some of the free drug, this can get really complicated, and offices are facing this more and more. And it's the most popular drugs, or the most commonly written drugs, that we're seeing coming up first. And it's not a rollout where it's like, oh, this name brand drug is doing this. They're doing it one thing for one diagnosis, one thing for another diagnosis, and one thing for another. And I've talked to pharma partners who are mightily struggling to get people enrolled in the M3P because they don't even understand all the finer points of enrollment and getting through. So their FRMs and partners are really struggling as well. So this is where I think with pharma and specialty pharmacy sides, we're going to have to all really work together here with our provider offices to get these patients enrolled and getting through the system in a more timely manner, because this is going to cause major holdups.
So all of this really highlights the importance of education and clarity. What resources or tools do you recommend for providers and patients to better understand the new process?
Sheri, CMS has done an absolutely lousy job of education. The stuff that's on their website, it took me some time to figure it out. And they address it to consumers, but forget it. If this consumer sitting here cannot figure it out, I've written things, but that doesn't do much good. So maybe Sheri has a better answer from her perspective, or maybe from the Pharmacy Association's perspective.
What I'm seeing coming this year that are just dropping, like I'm just seeing them in my inbox, even this morning, I saw another one come, is that some of the Medicare plans and Medicare Advantage plans are adding new tools for the 2026 plan year, knowing that this is open enrollment. So they are adding additional resources and things where patients and family members can go and get more information. I think how those are going to be, I don't know, because it's just going to depend on the plan and what was already there for patients. But I would say that there's also your specialty pharmacy and provider's office and patients that have access to their provider can always get information from the specialty pharmacy, even if they're not receiving it. They can always try to find. So I think that's a pretty good, if you're on a high cost drug, there will be a pharmacy that will provide education, and your provider can put you in touch with someone there. And you have to find the one that works with your PBM and your plan and all that. But there will be education available. You just may have to pick and choose and not go maybe to some of the ones you've used in the past, kind of branch out and use different things. But I do see the plan starting to add additional information. And I think all of the specialty pharmacies have guides to the M3P. They vary widely how useful and readable and, wonderful they are, but they all have provided those. So because specialty pharmacy is so entrenched in this world, they're really one of the few places where you do have a non-siloed, for the most part, viewpoint of the system, because we deal with our pharma partners, we deal with the payers, we deal with the patients, the providers. There's really nobody in that loop that we're not commonly dealing with as an entity. so that if you can get access to someone there, I think that's really your best bet. But I am hopeful that, maybe by 2027, a lot of these plan additional education things will be helpful. And then Diane hasn't mentioned yet, but she has a fantastic tool that I've been recommending to people. It's called heymo.com, where you can research, for Medicare specifically, you can research what plans would be best for you. You can type in the particulars of your exact situation and look at what the landscape will be for your 2026 year. And I think that's a fantastic tool. HEYMOE.com.
Oh, okay. Awesome.
MOE stands for Medicare Open Enrollment. And I think what sets us apart from Medicare.gov is looking at way more pharmacies, 15 of them, I think, and also the expertise of my partner and I in guiding it. Like I told Sheri, so many people with levothyroxine will enter a capsule, which the drug plans do not cover, and we will tell them change that to a tablet and those kinds of things. We do the interpretation. Medicare.gov Plan Finder does not. So thank you, Sheri, for mentioning it. It's been a lot of work, but it is a nifty little.
It's really a much needed tool, and I've been sharing it with provider offices as well, because I think it's helping them kind of navigate with their patients and the patients' families, because a lot of times there's several levels to dealing with just the levels of patients and paying their bills and HIPAA compliance and who's ordering for the patient. Remember that we have multiple people in that chain as well. It's not just a single person receiving the medication.
So this is really interesting, right? With all of this like direct to consumer type pricing models, right? And delivery models that we're hearing about, it's just very, very important that somebody have a complete patient profile, right? With all of these claims on there so that these programs do what they're supposed to do.
That would be ideal. And what's interesting is that patients often don't even have their own complete profile, because their profile is spread between their MyChart programs that are spread across health plans. Health organizations. And so if you're looking for the records of this doctor, you're going to log into one MyChart, another one over here, another one over here. And then if your insurance plan does not work with that health system anymore, or that's not where your provider is, or your provider moves, you suddenly have to try to pull stuff out and move things around. And often technology isn't fully accessible to patients who are receiving, these high cost drugs for one reason or the other. I just hung up the phone with a coordination person at an office, and she was calling to tell me she started chemo, and she was telling me the challenges of getting chemo, especially as a person, ironically, who coordinates meds as a living. And we were talking about it just personally, and she was like, it's just to be on the other side. I've always known what it's like to be on my side of the desk and had sympathy. But she's like, as you go through it, it's so incredibly frustrating. And she said, I don't have all my faculties. I'm sick as I'm doing this. And she's like, I think we forget how sick people are when we're talking to them on the phone, because it just becomes your normal. And when you work in the field, that people are sick and they're having issues. But she's like, I can't stay awake some days to make phone calls. And I think we forget that in the patient care access arena sometimes, that our patients who are getting these medications are the most at risk that we can probably deal with in the healthcare system. So they need more and more resources and education to make this easier for them. And this is an incredibly difficult program, just in general.
If I could back up on what she said at the beginning about the question that Sheila asked about a complete patient profile. As an old home care nurse, there is a condition of participation for home care that we have to do a complete medication regimen review and reconciliation and talking to the physician, right? And as an old home care nurse, when I would see medications prescribed by 6 different doctors and all kind of in the same class, it's like, okay. Now, what I find interesting, CMS, again, in its great wisdom, has proposed a supplemental benefit for Medicare Advantage plans. Supplemental benefits are not covered by Medicare. Medication reconciliation post-hospital discharge, okay? That is a supplemental benefit that the Advantage plans can choose to provide, which might get to the core of the problem that Sheila asked about. However, I have now reviewed 70 Medicare Advantage plans, and I have not found one plan that offers that as a supplemental benefit because I think it is such a major undertaking. They have no idea of the cost that would be involved, the time that you would spend verifying these drugs with different physicians, all the things that Sheri said. And that just shows you that there's a big issue. If the government's looking at medication reconciliation as not something that Medicare would not cover, and therefore we're just going to throw it along with dental and gym membership and transportation, it bothers me greatly as a nurse.
Sure. And so I think that's why it's so important, like at least if it was being adjudicated through their prescription benefit, right? At least all of the drugs are somewhere, right? I don't know about, people, other providers being able to access them, but the PBM or the Part D sponsor, whoever's doing that has that access at least. And the pharmacies, right? Then that would be returned to them saying, hey, they're on these duplicate meds. Now, whether or not people, intervene or not. But I just keep thinking about, as I hear more and more of these programs, we're going to kind of go around the insurance and we're going to go directly to the patient. But I don't think, like we were talking about in the beginning, I don't think people are thinking totally through what that means. Right? People are on more than one medication.
More than one medication to treat the same problem. And that's where you get into the side effects. And I know just personal experience, I'm sure we all have it. My daughter's father-in-law's confusion was increasing greatly. And I took one look at his drug regimen and I thought, oh my. And thankfully he had a primary care physician that paid attention based upon what I suggested. Cut his 12 meds down to 3. And it's amazing the difference that has made in this gentleman.
Oh, I'm sure. So what are some of the risks or pitfalls if patients aren't properly enrolled and informed about M3P?
I think the risks come more with the drug plan. There are, if the patient isn't properly informed, they're going to get hit with the higher cost, which is the risk of them not getting their medication, which Sheri has explained beautifully. The bigger problem, I think, if people don't understand the risks, I fear we're going to be coming to a problem with drug plans being stiffed. I get $2,000 worth of medications in January. Well, if I don't pay those monthly bills, the drug plan can kick me out of the M3P, but I still have my drug coverage, which I think is, there's a disconnect there. If I'm not paying the bills that the drug plan has already paid the pharmacy for, you can see where the risk is for the drug plan. And maybe, as I think about it now, speaking out loud, maybe that's part of the reason the education is lagging behind, because they face so much risk. At the end of the year, as I understand it, the drug plan is paying the pharmacies for medications in advance as the patients pick them up, like in November, right? Well, if the patient switches plans to a different company, there sits that first company with a bill.
But are they paying them proactively or retroactively? I can't imagine they're paying proactively.
No, their $2,000 is divided into 12 segments. I hit them up for $2,000 at the beginning of the year, and I pay $167 a month. So if I quit paying that plan in June, they're sitting on $1,000 that I owe them.
Right, but as the pharmacy, you still owe it to me because I gave it out.
Well, the pharmacies are being paid by the drug plan. The MPP does not affect the way that the pharmacies are being paid. CMS did confirm that in its 2026 final of the rules.
Okay, but you're right. Like the plans are carrying all the liability, and now they've become like debt collectors.
Yes.
So looking ahead, how can we as an industry better support continuity of care and adherence for those eligible for M3P?
I'll start. I think that what all of us can start to do from this day forward is think, how can we better educate patients? From my standpoint, as someone who goes into physician offices multiple times a day, I try always to come up with some sort of holistic concept of start to finish, how this is going to better help a patient and what we need to do to smooth out, pun intended, the problems for the patients, and looking at it as a holistic situation. So understanding that the patient, especially as we look into 2026 and patients changing plans, and a lot of CMS and different healthcare things will be changing in the next 12 to 18 months, and you have to keep up on that. So I think we all, if we're in a healthcare facing company, providing healthcare, working with healthcare providers, we have to really double down on our oath to better educate everyone who's providing services and make information as easy to find as possible. That means, languages other than English, helping people who have, need a bigger font size or can't access things on a smartphone or whatever their challenges may be. We need to try to help with this information gap so that everybody has an easy place to go where it's easy to look at a menu and find the information, because the coordinators in an office don't have hours to search through plan sites for enrollment links, right? That's just not feasible. And there's things besides this prescription smoothing program that they need to access. So we just really need to double down and work on education and overall better access to quality, up-to-date information for people and just better education. So if it means making a better flyer that incorporates all the parts of something for a patient, if we can help provide that to a provider's office and encourage them. Like, some of these drugs are incredibly complex to take, store, maintain, how the shipments work, REMS, black boxes, like it just adds up. But so if we can just take our piece and really double down on committing to give better education throughout the year, I think it will go a long way.
And Diane?
From my perspective, I don't have direct contact with patients, but we have included it in our educational information when patients are eligible for it, when we do their drug reviews, not HAMO, but our other drug reviews that we do include information on that. I do write about it through my Forbes column. I did the 2026 update right away in September when it came out. So from our perspective, I have a long list of coming up with, once we turn the corner into next year, it's my plan to be able to develop some of these short webinar types of things that we can post online. And this is on the list, along with probably 3 dozen other things. But anyway, it's there because people need education, because Medicare has become so complex. At a time in their life when they're slowing down, when they don't want to deal with computers anymore, what do we make them do?
Right. And it's very, very complicated, right? I've seen some of the calculations and it's very hard to follow.
That is true.
Well, and remember, the patients aren't seeing that, and they're only getting the information that their pharmacy is telling them. And also remember that patients, when you talk about in-network pharmacy, not all in-network pharmacies end up with the same copay for patients. And so the patient only knows what that one pharmacy is telling him in that one moment, and what their understanding of that copay is, whether it's monthly, bi-monthly, mail order 90 days, whatever you're talking about with them. There's complexities to just that one discrete price that we're communicating with that patient in that particular time, but it varies over time. So it's not simple.
No, not at all. Well, thank you both so much for chatting with me and sharing this valuable information.
Well, thank you
for putting it out.
Yes.
Mm-hmm.
A double thank you.
Yeah. All at the same time. As a reminder, NASP corporate members are invited to be my guest on one complimentary podcast per year. For more information about this or other NASP membership benefits and events, please feel free to reach out to membership at naspnet.org or visit our website at www.naspnet.org. Until next time, have a great day.